Thank you. And now the last talk of the series by Michael Morris about especially incorporating PSMA PET imaging into prostate cancer working group definition.
Thank you so much. What a wonderful conference this has been. It's my privilege to be here to talk in 10 minutes about SPARC and Prostate Cancer Working Group 4. Obviously, I'm speaking on behalf of a large group of people, many of whom are here, and certainly afterwards in the discussion, I invite any of those people to add to or readjust anything that I've said. These are my disclosures, and none of those really apply to these guidelines. So first about these two groups, they are have interrelated domains, but they are separate in many respects. SPARC is a consensus group on how PSMA PET should be reported and also creating a platform for that reporting. And that's specifically within the clinical contexts of primary staging, biochemical relapse, and response. Working Group 4 is really a clinical design framework and working group, and with a focus on developing drug and biomarker use for really regulatory purposes in the context of clinical trials in preparation of preparing those data for regulatory review and use. Now, obviously, within these two groups, there's a lot of common material on how to incorporate PSMA PET as an imaging modality, both in terms of how to describe those findings in a variety of clinical contexts, and then most importantly, and probably newest for everyone to sink their teeth into, how to report progression and response, much less how to define those entities. So, you know, there are members of these two international multidisciplinary groups who are committed to one of these consensus efforts or to the other, and then folks like myself who bridge those two in order to ensure that on an international level, everybody is talking to each other so that we don't end up with conflicting information and recommendations. And I should say in preparation for this talk that SPARC has been accepted for an EAU oral presentation that's coming up in another few weeks. Working Group 4 is sort of on the launch pad for submission. So between some embargo data and as well as an impending manuscript, I'm going to be careful about what I say here. So SPARC is an effort that really is trying to harmonize many different efforts that have been occurring internationally in order to harmonize and create a unified voice on how to report PSMA PET in an effort to improve efficiency, prioritization of what the key issues to be dealt with are, minimize the amount of heterogeneity and confusion for the field, and create unity where in the past many groups were proceeding on a parallel effort. I'm presenting this list as part of Anders' upcoming presentation of SPARC, so I attribute this slide to him. But as you can see, there are many different reporting recommendations that currently exist, both in terms of how to report staging, how to report the confidence that one has that lesions are actually disease versus not, and confidence of reporting progression or response. SPARC deals with all of these. It was through really a Delphi process that this multidisciplinary international group dealt with how to devise consensus around what that reporting should look like. And again, Anders will be discussing this in detail at his upcoming presentation. But there are, as I pivot now to Working Group 4, first of all, some common assumptions that are shared between SPARC and Working Group 4, and I think that there's been real effort to harmonize these otherwise very different groups. So first of all, there's recognition amongst both groups that there is no validated, and that's for regulatory purposes, response and progression criteria for any SUV-based changes, right? And so when we talk about PSMA PET, let's remember that PSMA PET is not a biomarker. I heard that a couple of times earlier today. PSMA PET is a device. A device is just a thing. It's just a machine. It outputs data. A biomarker is a specific quantitative entity that is linked to a clinical event. And right now we have candidate biomarkers, but we don't have definitive cutoffs. We don't know which of those candidates actually has the greatest association with a clinical event. We recognize in both groups that the CAT scan should be incorporated into the PET assessment and that RESIST will still apply, whether PSMA PET is ultimately positive or negative for a given lesion and will need to be reported. New lesions, in accord with what was said earlier today, will be defined on the basis of uptake, size, location, and pattern, so that nuclear medicine physicians and radiologists can be their best selves. It's not just some single absolute cutoff that meets or doesn't meet a specific threshold, but contextually within the context of the scan and the patient, you'll have a multi-parametric definition of new lesions. And then finally, the recognition, just as with bone scintigraphy, that with that first PSMA PET scan, there can be PSMA expression-related changes that are pharmacodynamic effects that have nothing to do with clinical benefit or progression. And so you should generally not either scan too early or will need to ignore that first on-treatment PSMA PET scan. Now, going down into the working group 4, first of all, again, a lot of people contributing to this effort. And I should say that I am only one amongst many people working on this. So first of all, a few special considerations. For the first and most important thing right now, we are stuck with bone scans as a standard for clinical trials, because bone scans are the only recognized imaging modality for bone that has regulatory recognition. And by recognition, I mean not only were the prospective trials done, but then submitted for regulatory scrutiny in the context of prospective clinical trials with a variety of drug therapeutics that you're all quite well familiar with. Second, there is the recognition that clinical trials are done on an international basis with a variety of centers who have in and of themselves a variety of financial and technological resources. So the criteria that need to be developed can't be dependent on bespoke proprietary software that only certain sites have, and the criteria need to be feasible on standard workstations. In terms of responses and progression, as I discussed before, response, very difficult to define either on bone scintigraphy or, for the time being, with PSMA PET. So we need to collect the data so that we should have an answer for working group 5. So working group 4 is in large part going to be a call for collecting those PSMA-based data points so that we can then analyze those from prospective studies and actually come up with the candidate biomarker that is optimized with a cutoff that is optimized. The same would apply for progression. But I would say that a new lesion is probably indeed new disease and represents progressive disease. And so very similar to early iterations of prostate cancer working groups, time to event analyses and endpoints will probably carry the day. So a new lesion is likely progression, but and I'm going to discuss this in more detail with some caveats. So for eligibility for standard imaging, it's going to be the same as prostate cancer working group 3 for the large part, but we recognize that there are going to be many clinical trials that are focused on the PSMA avid lesion with or without an anatomic correlate. So what we would say is avoid SUV-based criteria for defining progressive disease for the purposes of eligibility and focus on new lesions relative to some prior available PSMA PET. Now, in terms of defining progression, I think that we are going to move forward a little bit from working group 3. So this is from an analysis that we had done at MSK, looking at plain old bone scans using the automated BSI. The bone scan index is a quantitative method of assessing the fraction of tumor represented in the denominator of the total skeletal mass. And what we found was that above a certain threshold of BSI, which was 0.6, there was no improvement in the correlation between rPFS and OS. As you can see, that correlation, the Kendall's tau, remained at around 0.5, even though the patient had more and more disease, waiting for the prostate cancer working group 3 endpoints to be met. Indeed, if you look at the formation of 2 new lesions, the patient's overall burden of disease increased by 95%. And for that confirmatory scan, it was an incremental increase of 245%. So waiting for confirmation, the 2 + 0 component of working group 3 actually doesn't help your endpoint in terms of the correlation coefficient, but it does put the patient's safety in some jeopardy. Now, as we think about moving into PSMA PET, by the same token as we don't want to wait too long, we don't want to declare progression too early, right? And that's the risk of a PSMA PET. It becomes positive much earlier than a bone scan. I just want to say that in terms of looking at this relationship of rPFS and OS, we found the same in an unpublished, because we just did this analysis about 4 days ago. So please don't post this in any way because it's not ready for prime time. But we looked at the alliance trial of ENZA versus ENZA and ABI and Cougar 302. And also we found that there is a plateau of that relationship between rPFS and OS after that 0.6 of BSI had been reached. And again, more disease is bad for the patient. More disease doesn't necessarily help your intermediate endpoint. So with PSMA PET, we are going to distinguish oligometastatic disease from polymetastatic progression. And polymetastatic progression will not require a confirmatory scan. And I think that that's important to recognize. So, for example, the patient, let's say these are progression scans. So the new lesions on the left, we don't want to declare progression too early. So that patient, we would encourage a second scan and a confirmatory scan in order to ensure that those lesions are indeed progressive disease. And this patient can likely afford to have that wait, so to speak. And you would have to coach patients, just as we do now in terms of rising PSA, that we're not going to just remove you from study on the basis of a couple of new lesions on a PSMA PET scan. On the other hand, on the image on the right, that patient is unlikely going to have a new definition of where he progressed if that is his progression scan. And indeed, it wouldn't likely change the timing of the rPFS declaration of disease. And so that patient, we would say, needs no confirmatory scan in order to be declared as having progressive disease. Sorry if that sounds complicated, but I think it's an important point. The other thing in the name of patient safety is if you see on a PSMA PET scan the emergence of visceral disease, especially non-pulmonary visceral disease like liver disease, you do not need to wait to see that on an MRI or a CT to declare the patient as progressing. If you see the emergence of liver metastases, waiting for that to become more evident or more cumulative over the course of time is probably not in the patient's best interest. So I'm going to conclude here because my 10 minutes are up, but I would say that both of these are trying to develop greater uniformity of reporting, uniformity in recognizing and developing endpoints, but we are modifying working group 4 in order to improve patient safety. That's unlikely going to result in altering the time or the relationship between rPFS and OS, and new considerations of defining progressive disease on PSMA PET for at least a progression endpoint, because we have a lot more work to do to qualify what progression is and especially what response looks like. Thank you very much.